Thanks everybody for tuning in this morning. Um, I'm here to talk to you about a topic that I'm very passionate about, and that's the hidden risks of life support and understanding ventilator-induced organ injury. So, tell you a little bit about myself. I'm a respiratory therapist, currently working at Royal Columbian Hospital. I've been a respiratory therapist for about 20 years. And in my clinical role, I actually deliver life support. I actually look after patients who are on life support. So our patients are sick, they come into the hospital, critically ill, and we need to take over their breathing for them. So we will put them onto a mechanical ventilator, manage them through their critical illness on that ventilator, and then wean them off the ventilator before we discharge them from hospital. And so my clinical role, I manage that process. I also do ventilation research. So I'm the academic research lead for the Advancing Innovation in Medicine Research Institute, hosted at the Royal Columbian Hospital Foundation. And in our uh, institute, I do a lot of mechanical ventilation research. So being able to deliver mechanical ventilation more safely and being able to get patients off the ventilator better than the way we do today and quicker, hopefully. I'm the editor-in-chief of the Canadian Journal of Respiratory Therapists, where we disseminate our research information. And then I have the TB Vets Charitable Professorship in Respiratory Care at the BPK department up at SFU. And I got to teach my first respiratory physiology course this last semester to third year students. So imparting some of the knowledge there as well. I have some disclosures that are relevant to this presentation. I've had research support and consulting fees from Lung Pacer Medical, Blackford Biomedical research support from TB Vets, which are amazing, and then some grant support from BC Lung Association and from our hospital foundation. So just a little bit about me. So this presentation is going to cover a little bit what are ventilators and how do we use them. Everybody associated with TB Vets probably has had a bit of exposure to mechanical ventilation, but just in case, I will go through it, talk about how they can cause harm, even though we need them to support life, and then talk about the current innovations and solutions that we have and are working on to try to do it better. I've put Q&A at the end of the agenda, but please feel free to stop at any time or put your questions in the chat. I'm happy to address them as they come up. So let's talk a little bit about our ICU landscape. So patients coming into the hospital that are admitted into the intensive care unit are our sickest and most critically ill patients. And so obviously they need the most support. And as you can see in these pictures, whether it's premature babies admitted into the neonatal ICU, through the pediatric ICU, into the adult ICU, the amount of technology that we need to support these patients with is quite significant. There's lots of monitors, there's lots of machines. The mechanical ventilator is attached to a breathing tube that's inserted into the patient, and that takes over all of the breathing for the patients. So we put the tube in, put them onto the ventilator, and then manage them through their illness. The ICU landscape pictures here are to just show you the complexity and the seriousness of these patients. So these are the sickest of the sick, and they require a lot of complexity to be able to be managed. Mechanical ventilation use is quite significant. So if we look at in Canada, about 291 patients per 100,000 people require mechanical ventilation. And if we look at between $2,000 and $3,000 a day to manage them, this takes up quite a significant amount of our resources. So we're talking about 1.9 to $2.8 billion Canadian yearly to look after our critically ill mechanically ventilated patients. So there's a huge burden to our medical resources to look after these patients. And anything that we can do to reduce that burden not only is better for the patients, but also is better for our resource-strapped medical system. If I save 1 day of mechanical ventilation per patient in British Columbia, I save $10 million a year out of our budget. So this is a big burden and a problem worth trying to find some solutions for. So Obviously, breath is life. We're all sitting here today breathing, and that's what's keeping our brains and our hearts active and gives us the ability to be who we are. In the early 60s, with the polio epidemic out of Sweden, mechanical ventilators were born. Dr. Ibsen was a anesthesiologist who realized that by putting a hole in somebody's trachea and putting a tube in, that we could mechanically ventilate somebody with polio. And we took the death rate from polio from being 80 to 90% down to 20% within literally a 3-week period in Copenhagen, which was phenomenal. And out of that was born the iron lung, which is the picture at the top of our screen here. So we managed patients in an iron lung where their head was out and their body was inside the iron lung, and the pressures would be varied within the lung, and that's how we helped them breathe. And patients would live in these lungs for years. The last iron lung patient just died in the last year, I believe. Somebody who chose to live on his iron lung for his life because that's how he was comfortable. And as you can see with the bottom picture here, ventilators have obviously technologically advanced significantly since the 60s. So now we have these very advanced machines that have various valves within them, various abilities to push air, pull air, very highly complex monitors, tons and tons of data that's coming out of them. And obviously, this is the machine that helps patients breathe when they cannot on their own. So the machine is capable of taking over all of the breathing, or when a patient is in a coma, or being able to just supplement a patient's natural breathing. Ventilators are common in the ICU. They're used for surgery, obviously in the emergency department, and their whole function is support for failing lungs. They can do oxygen delivery. They allow us to have time to heal if it's a lung problem, or time to no longer have to be in a coma if it's a non-lung problem. And their whole function is to push air into the lungs. So we breathe right now using negative pressure ventilation. Our brain decides that we want a breath. And so our brain says it's time to breathe. It sends a signal down our nerves, our phrenic nerves that run on each side of our neck, down into our chest. And that sends information to our breathing muscles to say we want to have a breath. Our chest muscles and our diaphragm, which is the muscle at the bottom of our lungs, all contract in unison, and that pulls our chest wall out and our diaphragm, our abdominal contents down, and that creates negative pressure inside of our lungs. We open a flap at the back of our throat at the same time, and then pressure just equalizes down a gradient from positive pressure at the atmosphere to negative pressure inside the lungs, and flow goes in. When we decide that it's time to stop breathing, our brain sends the signal to those muscles, they stop contracting and they relax. And then with through elastic recoil, that flow reverses and the air goes back out, and that's how we exhale. So we need to now achieve that with a machine that's not attached to the brain. So we have to be able to listen when the patient breathes or wants a breath if they're breathing spontaneously, or be able to give it to them in a way that we think that they need. And all the guesswork is done from the outside. So we're not able to see inside the patient's lungs in real time. We have to decide what the brain wants. And so it becomes a little bit, that's the art to the science, right? So there's lots of technology that's been built into the machines to be able to listen for patient signals and be able to understand that it's time to give the breath that the patient wants. But the machines are not able to respond as quickly to what the patient needs as what our brains are able to do, obviously, right? Or our bodies are able to listen to our brains. Now we have to do all of that outside of the body. And then we have delays that are in the system. So we need signals to travel from whether it's a flow sensor that's picking up a pressure difference to detect a patient's breath. And that signal needs to now travel from where we're sensing that change back to the computer that's inside of the ventilator. It needs to be processed. The valves need to get that signal, and then they need to start pushing air. So there's inherent delays that are built into the system, and inability to really do things perfectly physiologically. And it's those delays and non-physiological delivery of breath that causes a lot of the harm that we're going to talk about today. So when help hurts, ventilator-induced lung injury. So apologies for a bit of a graphic picture on your screen, but this actually is a very nice way to show you what actually can happen to the lungs when we don't get it right. So this is a picture of rat lungs that are ventilated over a period of 20 minutes. So the set of lungs on the left are normal lungs that have just started to be ventilated. So this, take my word for it, is what healthy lungs look like. So they're nice and plump and they've got good color. After 5 minutes of high airway pressures, you're starting to see that the lungs are starting to look quite different. They're getting really kind of blotchy and their shape is completely changing. And after 20 minutes of ventilation, now we have lungs that are very, very injured. So you can see that there's bleeding that's happening, they're very swollen, and those are very injured lungs. Now that happened in 20 minutes with pressures that are high, but not exorbitantly high. And so we have to be really careful when we ventilate patients to make sure that we don't cause this scenario. So when we talk about ventilator-induced lung injury, there's different ways that it can happen. So if we give the wrong volume to our patients, then we're going to overstretch the lungs and we're going to create those very beaten up looking lungs. The size of our lungs is based on our sex at birth and our height. It's not actually based on how much we weigh. And so we tend to often overestimate the size of our female patients' lungs, and we tend to give our female patients volumes that are too high. So female patients actually tend to be more at risk of ventilator-induced lung injury. Um, we need to control how much how much volume we give our patients, and we try to stay under 8 mils per kilo of ideal body weight. So for an average sized woman of 50 kilos, that's about 400 mils of tidal volume or less. And then for men, that'll be a little bit more. And obviously, when we're talking about premature babies, the smallest patient I've looked after in my career was 273 grams. A baby born at 23 and a half weeks gestation, that was less than a pound of butter. So that baby we were ventilating with 2 mils of volume. So very, very, very tiny, right? So we need to get the volume right. We also need to control the pressures. Your lungs, whether it's due to the disease process that's in place or due to other factors that have got you into the ICU, can become very stiff. Our lungs right now, all of us here on the call with healthy lungs, have very stretchy lungs. It doesn't take a lot of pressure to get our volume in. But when we get very sick and we go onto a ventilator, now the pressure that we need to ventilate patients also goes up. So we need to generate more pressure. So the high volume is injurious, high pressure is injurious. The other thing that happens is lying down in a bed means that we have the effects of gravity. So as we sit right now, our lungs are sort of very uniformly open. Inside of our lungs, we have these little air sacs called alveoli, and they look like little raspberries all the way through our lungs. And all of those little raspberries are sort of very uniformly open, and they're all uniformly stretchy. And so when we breathe in, that volume nicely distributes everywhere through our lungs, and everybody takes their own little share of the volume. But if you go and lay down in bed for a week and you're not really moving and you're not really doing very much, the area of your lungs that's closest to gravity will start to collapse. So all of those little raspberries, due to the effects of gravity, start to close. And so now, if we had 1 million units in the lung that were taking the tidal volume and we're losing 20 or 30% of those units due to that collapse, now we have less space to transmit or to distribute that volume through. And so the air that we put in, we need to be careful about how much it is. And then if we're having that collapse happen, it's called atelectasis, then we're going to distribute that air into places non-uniformly, and that causes injury. And then sometimes those collapsed raspberries or alveoli will open and close through the breath. So when you breathe in, they will open up because air is going in, but when you breathe out, they actually collapse all the way back down. And so the walls of the alveoli opening and closing and tearing apart and closing back together causes injury as well. And so this is just a graphical example of sort of in a normal alveolus, we have little macrophages that go around and sort of clean and eat all the dirt. We have nice gas exchange. We have really nice interface between the alveolus wall and the little blood capillary vessel that's running next to it for our gas exchange to happen. But on the right-hand side of your screen, when you look at what an injured alveolus looks like, now we have breaks in the alveolar membrane. We have flooding that's happening between the capillary bed and the alveolus, making that gas exchange distance go further and more inefficient. The vessels start getting injured. So all of this starts creating inefficient gas exchange. So now the oxygen doesn't cross well into the bloodstream to go up to the brain, and this carbon dioxide doesn't come back out very well. So we have to ventilate more because now our efficiency is going down. So if you only needed 10 breaths per minute to have good gas exchange, now maybe you need 15 breaths per minute. And every breath is exacerbating the damage. So it becomes this positive feedback loop of injury. And then when we have these breaks and we fix the breaks, our tissue fixes the breaks, we lay down fibrin and fibrosis and we put on scar tissue. And that scar tissue then stays for life. So then we actually permanently alter the lungs. And now these are the patients that are discharged from ICU with oxygen. So it sounds like a bad news story all around, but at the end of the day, we have to be able to keep our patients alive because the option, if we don't breathe for them, is that they are going to die. And so we accept this sort of cost of ventilation and this injury as we go through. But there are ways for us to do it safer. And as our technology changes, we're able to do it even safer. And some of the research that I've done shows that if you already have an existing lung injury, so if you're somebody who comes in, say, for example, you've got a pneumonia with the flu, and so you have an injured lung already, and then we put you onto a ventilator, your risk of ventilator-induced injury goes up significantly. So 3 to 5 times faster that you will get ventilator-induced lung injury if you started with an injured lung. So our injured lung patients, we actually have to be the most careful of. And so this figure one here shows how that distribution of ventilation changes when you're breathing yourself negatively, negative pressure ventilation with contracting your respiratory muscles. 60% of your volume of your lungs goes into the bottom half of your lungs, and only 40% goes into the top half. But if I sedate you and I put you on a ventilator and I breathe for you with the ventilator, that ratio reverses. So now 60% of of your volume goes into the upper half of your lungs, and only 40% goes down to the lower end. And what that does is it drives that gravity collapse, that atelectasis that we see, because not the bottom half of the lungs is the most prone to the gravity effect, and it doesn't have enough volume to keep itself open. And so here in figure three, if we look at the pink slide, oh, sorry, my mouse is very sensitive. If we look at this NV column here, that is a cross section of pig lungs that are normal, that are just breathing spontaneously. And so you can see all the beautiful white space in between all of the pink. And so you can see whether it's section one, which is the bottom of the lung, up to section five, which is the top of the lung. Those lungs are beautifully open and it looks the same through all the regions of the lung. But if we look at animals that were ventilated for 50 hours on a ventilator, so that's not long, right? That's just over 2 days. You can see that in the bottom parts, one and two are very significantly collapsed. So there's no white space, there's no air in those lungs, and that the very top part is quite overstretched. And then the LIMV group is the group that had a pre-existing lung injury that were only ventilated for 12 hours. And so normal lungs for 50 hours was less bad than injured lung for 12 hours. And so again, you can see that heterogeneity from the bottom of the lung up to the top of the lung. So, ventilators can injure the lungs, and if you're starting out with a sick lung, the ventilator injury is you're much more susceptible to it, is the take-home message from that. But injury doesn't just um, sit with the lungs. So, injury in the lungs actually communicates and drives injury outside of the lungs because all of our organs in our body are in communication with each other because blood circulates through all of our organs. So, lung inflammation can actually affect the liver, the kidney, the gut, the heart, and particularly the brain. And so, the ventilator induced lung injury has been well established and everybody accepts it. But the understanding of how ventilator induced organ injury is affecting the other organs in the body is a very big area of research right now. And we're starting to get a really much better understanding of how the injury happens and ways that we can uh, fix it or at least prevent it. So let's look at the diaphragm. So ventilator-induced diaphragm dysfunction. So like I said, for us to breathe right now, our biggest breathing muscle that we use in our body is our diaphragm. It's the muscle that sits at the bottom of the lungs, sort of just above your waist, and it does 70% of your work of breathing. So when you are intubated and sedated in the ICU and you're not breathing for yourself, you're not contracting that muscle. That muscle is designed evolutionarily to be able to be working all the time from when you're born to when you die. That muscle is meant to be contracting in a rhythm across your whole life. So it's not meant to stop working. When we sedate patients and we stop that muscle from working, it atrophies very quickly. It becomes weak very, very quickly. So we get fiber atrophy, we get contractile dysfunction, we've seen ultrastructure changes in diaphragm fibers, and then there's oxidation of lipids and proteins. So not only does it get weak, but we actually get chemical changes within the muscle that cause injury of the muscle. And so you lose 6% of your diaphragm function per day. And in 18 hours, you can have significant reduction in your ability to breathe just due to diaphragm weakness. So this has been a big area of research over the last 15 years to try to understand how can we keep the diaphragm working, and then how can we maybe keep the diaphragm active in patients that are sedated and comatose? Because if your diaphragm is weak and we need to now get you off the ventilator, we have to get your diaphragm strong again back to a point that you can be able to come off the ventilator and be able to manage your breathing yourself because it does 70% of your breathing. And so it's a very important muscle and one that we need to take care of in these patients. Our kidneys are impacted too, mostly because of changes in blood flow in ventilation. Because we're putting pressure from the outside into the chest using the mechanical ventilator, that changes how the blood flow goes from the heart. And we'll get into that in another slide. But those changes in blood flow and decreased cardiac output means that the kidneys perhaps are not getting the blood flow that they need. And that can actually lead to kidney damage quite quickly. And then there's also what we call biotrauma from the lungs. So that picture that I had of the damaged lung, where you have all the little inflammatory markers crossing from the damaged lung into the bloodstream. Now those inflammatory markers getting circulated, where they pass by, inflammatory markers like their friends, they invite their friends to the party. And so they stimulate other inflammation. Inflammation causes inflammation. And so you can have inflammation in the lung, and then those inflammatory markers travel through the rest of the body. And as it's like hitting the kidney, now all of a sudden those inflammatory markers are like, woohoo, let's start a party here. And now we start inflammation in the kidney. And so that's how injury starts. If we have kidney injury in our ventilated patients and they're not able to, their kidneys don't work very well, so they don't have the ability to eliminate their urine properly, and then they accumulate fluid in their bodies, that fluid backs up into the lungs and makes it harder for the lungs to be functional. And now it's harder for us to get them off the ventilator. So not only do we need the lungs to work well, but we need the kidneys to work well. If only people were less complex, this whole situation would be much easier to manage. So The diaphragm gets weak. We injure the kidneys due to changes in blood flow and inflammation. We actually have a very significant impact on the brain, and this has not been recognized up until about 5 years ago. And so a stay in the ICU can leave you with brain injury equivalent to a moderate concussion when you leave. And this is much more appreciated today than ever before. And I've participated in some of this research, and it's fascinating. So, we talk about ventilator associated brain injury. And this is due to two things. So, those circulating inflammatory markers from the lung can go up to the brain and start an injury. And the injury process happens in a place called the hippocampus, which is the part of your brain that makes memories and helps you with cognitive function. And so, how ventilator associated brain injury manifests is we actually see cell death in the hippocampus, and we call it apoptosis. So the cells within the actually die, and you have a natural death and regeneration of those cells that happens as the brain keeps itself healthy, but it happens at a much higher rate than the natural regeneration. It's death without regeneration. And so this leads to long-term cognitive impairment and can actually lead to long-term disability as well. So that's the inflammatory circulating markers. But then we're also starting to see a lot of evidence that there is a feedback loop with breathing that sends a positive signal to your brain that all is good, and that keeps everything in a good place. We call it homeostasis. So if my all my respiratory muscles are contracting and I've got good signal going down my phrenic nerves, there's a signal that goes from all of those muscles back to the brain that goes up your vagus nerve, and that seems to be a positive signal for brain health to continue. And so we don't quite understand the communication loop yet, but we do know that it is involved. And so if you can interrupt that signal, you cause the same injury in patients that are still breathing. And if you stimulate the vagus nerve in somebody who's not breathing, you can avoid this brain injury. So there is lots of solutions looking at vagal stimulation, and stimulation of the vagus nerve is a very interesting field of research right now. It looks like it has positive effects in post-traumatic stress disorder, in lots of mental health applicability. And so maybe this is due to this positive feedback signaling that is happening. And then there's secondary brain injury in patients who already have a brain injury. And this is the same message as we go through all the organs, right? Is that if there's already an injury, going onto a ventilator is probably going to hurt that injury a little bit more and cause some significant challenges. And that's due to reduced cardiac output and changes in pressures within the body, things like that as well. I promise I'm getting to the good news eventually. And then the impact on the heart. So we do injury to our heart, and that's by putting pressure into the thorax with the lungs and having to ventilate patients, particularly in lungs that become very stiff and need a lot of pressure. That pressure gets transmitted to the heart, and so it makes it difficult for the heart to beat and to be able to do its own pressure changes and to keep blood flowing forward. So we end up with the left ventricle of the heart working less well, and then blood backs up through the lungs, and then the right ventricle becomes very overdistended, and the whole system becomes very inefficient. So, getting the ventilator right or not paying attention to the mechanical ventilation protocol that we're using can have a significant effect on all of the really major organs within our patients. And then we are starting to understand that there's also an impact on the liver and the gut. So again, inflammation is bad for your gut, it's bad for your liver, and all of these can then have this positive feedback loop back into the lungs as well. So it can become this self fulfilling prophecy. So, how can we reduce all the harms that I've just gone through? So, we work really hard at at providing what we call lung protective ventilation strategies. So we know that keeping volumes, 6 to 8 mils per kilo ideal body weight is in the safe zone. We know that keeping pressures under a certain level. We know that giving stretch pressures within a certain range um, is where we need to be. We know that we need to keep all of those little raspberries open, and we use special pressures to be able to keep them open and combat some of that gravity collapse. Um, and so in the lungs, we have lots of strategies for us to be able to, and very well researched strategies to be able to make ventilation as safe as possible. And so if we stay in these ranges of safe ventilation, that we will minimize the impact of these injuries to all the organs that I have just gone through. And so the current strategies fall into two different buckets right now when we think just of the lung and the diaphragm. So we talk about minimizing lung stress and strain. So we need to think that we are ventilating a baby lung. So the ability to take volume in our lungs as we're sitting listening to this presentation right now is quite significant. We're breathing, maybe 350 to 500 mils, but we can take up to 3 liters of volume and we won't injure our lungs. No problem. We've got lots of room to go. Somebody who's sick and whose lungs are inflamed is working with a baby lung. So they have way less ability for big volume swings. So we make sure that we keep their volumes in that really, really, really tight range that is good for that particular patient. And by doing so, we make sure that the pressures that we're using to deliver that volume are also in a safe range. If we keep those two things safe, we can minimize the amount of stress and strain that we're transmitting from the ventilator to the patient's lung tissue. The other thing that we do is try to optimize patient effort and synchrony. So we need to try to make sure that patients are breathing for themselves as much as possible. So these are things like minimizing the amount of sedation that we give patients, making sure that they're breathing on their own as soon as they can. For as long as they can. But then we also need the ventilator to be as synchronous to their breathing as possible because these patients are breathing through the equivalent of a straw to a machine that's trying to follow what they want. And if that synchrony gets, if those two things get too out of sync, then it becomes very, very uncomfortable. And sometimes the only thing we can do is then sedate the patient to be able to let the synchrony build back up and then try again. And so making sure the patients are breathing on their own for as long as they can, and then making the ventilator as synchronous as possible to those patients goes a long way into reducing the injury that we see. Something that got a lot of attention in COVID that we were doing pre-COVID, but more rarely, and now we're much quicker to do, is what we call prone positioning. So if you think about patients laying in bed in the hospital, everybody's laying on their back because that's just most patients are more comfortable that way, and you have better access to the parts of the patient that you need to give care. But for sick lungs, it's actually really beneficial to take patients and manage them on their stomach. So we actually put them face down in bed for 18 hours a day. And so they'll do 6 hours facing the ceiling, and then we'll flip them over onto their stomachs for 18 hours a day. And what that does is it changes where gravity is affecting those raspberries to collapse. So we make sure that those collapsed areas all open up when the patient's laying face down. But the way that the lungs are suspended in the chest cavity and the way that they attach to the spine, the collapse is actually less when they're laying on their fronts than when they're laying on their backs because the lungs are suspended differently, the way that they're tethered and anchored. It's really interesting. It's also the way that the abdominal contents impacts pressures up onto the lungs when you're laying on your back than when you're laying on your front. So there was a study that came out just before COVID that showed a 16% mortality improvement managing patients like this, which is huge in ventilation research. If you can improve mortality by 16%, it's massive. And that overcame the barrier because it's very resource intensive to have to roll people onto their fronts. So for us low tech hospitals in Canada, we do it by manpower. So literally six of us are three on each side of the patient. We sort of burrito the patient into a couple of sheets. We literally like roll them up like a burrito, and then we have to do this very careful, slow, because these are patients are sedated, they're in a coma. So they, we have to do everything for them, and they have lots of lines and tubes and really important lines and tubes attached to them. So we literally sort of inch them over up onto their side and eventually get them turned over onto their front. And then we have very special pressure pillows to go under the face and under the shoulders and under the hips to be able to try to keep some of the pressures off, and be able to access the lines and tubes that we need to be able to access. And when you do it right, it works great. And it saved a lot of lives. It saved a lot of lives in COVID. So it's one of our really low tech solutions. In the States, where they have tons and tons of money for this kind of stuff, they actually have proning beds where the whole bed just goes and the whole bed flips over, but they're like hundreds of thousands of dollars. And I don't know that I would spend that resource if I had that budget. So,
Yeah, I was gonna say, sorry to cut in, but it's so interesting because you describing it by doing it just by manpower was how I
hmm
imagined it before you
hmm
described it too.
yeah,
And it kind of lends itself to, I don't know if this is me just being me, but like a holistic approach to like evening the body out as well. I don't know,
it's
I,
very much, yeah.
yeah,
So, our bodies weren't made to sit all day. Our bodies
yeah,
weren't made to lie down in bed all day, right? Our bodies are
exactly.
designed to lay in that position for about 8 hours.
Yep,
And so when you're in bed for significant periods of time, and super interesting when you look at the research around, so they're looking at this a lot for astronauts and like thinking about people going to Mars and having to, be in a travel bed for 3 years potentially to get
exactly.
to Mars. They've done experiments where healthy volunteers have offered to lay in bed for 2 weeks, or any poor pregnant person who's had to be on bed rest, for months at a time. There's very significant physiological changes that happen to your body when you're in those
Yeah,
positions. And so we definitely, for our poor ventilated patients, this flipping of them has really, really made a huge difference. And anybody can do it. Any hospital anywhere in the world, resource wise, you don't need a $300,000 proning bed to be able to do it, which is um, figuring out these answers in high tech solutions is great. But
yeah,
when the price of that technology makes it so unable to be,
inequitable.
yeah, it's that inequity, right? And
Yeah,
so yeah, that's a whole nother webinar, I think, about the equity
yeah,
of healthcare delivery.
for
It's a little
sure
bit
it
of a
is.
passion of mine. So
Yeah, I think that's
um
what I like the most about it is you could do this in almost any situation, given that you knew it was a
for
possibility.
sure. And so in COVID, what was fascinating was when we started COVID, because obviously it was something new and we had some experience from SARS, but when COVID started, we really got an like we really quickly had to try to understand because these patients were different. And so somebody with a COVID pneumonia was different than your regular pneumonia patient. Their lungs actually behave differently.
Yeah.
And so we were intubating patients very quickly at the start of COVID, and we realized that was doing much more harm, that they could actually, all they needed was oxygen. They didn't need the ventilator. And so what we started doing is we started having awake patients start doing this. And so we
Mm,
would make our awake patients, bad COVID patients who were just on like 100% oxygen, really, really sick, but managing to not be on the ventilator. And we prevented them from having to go on the ventilator by having them
mm,
do this themselves voluntarily. And so then they
amazing.
would just flip themselves and just lay face down in bed for 18 hours a day, which, sucked, but
Yeah, but
saved their lives. And
save
so
lives.
we
Yeah.
learned a lot. COVID was fascinating from this perspective. So there was a lot of very fast decisions and research and knowledge that was spread, which was, I guess, the silver lining that came out of it. So
Yeah. And I like that you mentioned even with like a high level of advancement of technology, this is something that you're gonna benefit from regardless and is relatively not easy to do if if someone's
yeah,
unconscious, but you could do it.
But you can do it, and
Yeah,
you can train people to do it,
exactly.
and as long as you go slowly, you can do it very easily.
Yeah, and
So
it's almost more inspiring than than a technological advancement to me, at least, because
yeah,
it's also universally understandable.
absolutely, for
Yeah.
sure.
Cool.
Yeah,
Thank you for
awesome.
letting me interject.
Yeah, you're welcome. Um, and then our ultimate lung and diaphragm protection strategy is actually to put patients onto what we call ECMO, so extracorporeal membrane oxygenation, and that's heart-lung bypass. So that's when we take all the blood volume out of the body through various cannulas and tubing systems and pumps, and we actually do the oxygenation and the carbon dioxide exchange outside of the lungs. The ability to do this safely and with slightly lower resources has come a long way in the last 5 years. And so we're much quicker because we're able to, like the hospitals have more staff trained to do it. So where before, for example, a really, really, really um, bad pneumonia or a really, really bad asthmatic that really could not breathe at all. And we would just limp along for a very long time and do a lot of injury with the ventilator before, and this would be the last ditch resort before they died. Um, or before we're past that point of no return, we will go to this now much earlier. And so, and that's just a complete rest. Everything is being done outside. There is a ventilator, but it's not actually delivering breaths. And so it's considered to be a lot safer, but certainly a very high level of technology. So, innovations, where are we going? So, I did my PhD looking at diaphragm neurostimulation. And so, this is this attempt to be able to restore that physiological way of breathing, keeping the muscles contracting, keeping that distribution of air to be a very much healthy, normal way of distribution within the lungs, but in a patient who's actually sedated and not able to do that themselves. So, I talked earlier about how natural breathing is negative pressure ventilation by the contraction of your muscles due to a brain signal. Whereas when we sedate somebody and we put them onto a ventilator, we have to positively pressure ventilate them. So we're pushing, we all breathe. If you think about your vacuum cleaner, so we all breathe by vacuum clean, like sort of like a vacuum cleaner. Whereas when you put somebody onto a ventilator, it's like making them breathe with a hair dryer. And so it's where the breath goes is different. If we can stimulate that muscle, the muscles to contract in somebody who is not awake and get that muscle contraction coordinated with the ventilator, now we kind of have the best of both worlds. And so can we give that diaphragm, can tell the diaphragm it's time to contract and make it nice and synchronous to the ventilator? Yes, we can, absolutely. So there's three different technologies that have been developed and that all are in clinical trials right now. One has been approved. So the one that I did my PhD in just got FDA approval, which is super exciting. But there's also two other horses in the race. So what this requires is to be able to send an electrical signal to the diaphragm using the phrenic nerves. So the phrenic nerves are the two nerves that go down the side of your neck, as seen here in this picture. So what I studied during my PhD was to put a big catheter or a big IV in through the big left neck vein. And that catheter has little electrodes embedded on it that when it sits in the right position, those electrodes can send an electrical signal to the two nerves going down each side of your body, and that can cause that diaphragm to contract. It can control that contraction with high reliability. So it starts when we want it to start, it stops when we want it to stop, and we can vary how strong it contracts. And all of that is synchronized up to the ventilator. Then there is non-invasive ways to do it. So using magnetic stimulation, so you can use magnets to send that same signal using a coil that sits on the outside of the neck. The research coming data coming out of that group shows that it's not quite as controllable because as patients are moving in the bed, those magnets will be moving around slightly differently. But it means nothing needs to go in the body. It's all done on the outside. And then there's surgical implantation. So there can be temporary wires put on the diaphragm, or there can be permanent pacemakers put into the spine, which is what we support a lot of our spinal cord patients. So there are spinal cord patients who have lived for years with permanent implanted spinal cord pacemakers helping them breathe, and meaning that they don't need to live on a ventilator. So, this temporary diaphragm neurostimulation is a new technology that is very exciting, and that will not only allow us to keep that diaphragm muscle strong so that we don't have the weakness developing and the difficulty weaning off, but can also actually help us from perhaps not creating the lung injury and the other organ injury in the first place. So, all of the research that has been published in this topic, we've shown that so that we can reduce what we call dorsal atelectasis and improve gas exchange. So, we can reduce those raspberries collapsing due to gravity if we keep the diaphragm contracting, so way less. And so, we have better volume distribution and less lung injury. Improved gas exchange means the lungs are working better. So we need to give less ventilation because we're getting better bang for each breath that we're putting in. By contracting the diaphragm, keeping the raspberries open, we have increased lung volume and reduced stress and strain. So we've got more little units that we can distribute that volume between. We have shown in pigs, and we have also shown in people now, we just published this week, that we have reduced brain injury using this technology. So, in adding diaphragm neurostimulation to a mechanical ventilation protocol means that we have less hippocampal inflammation and apoptosis, less brain inflammatory markers. So the next steps would be to actually do the cognitive tests when patients are in ICU and post to see if we actually not only improve the blood work, but do we actually have a functional improvement as well. And we've shown that we have improvements to the heart, so we have better cardiac output when we have that diaphragm pump happening as well, and obviously the diaphragm disuse atrophy and weakness is less. So diaphragm neurostimulation is a very, very exciting tool in our toolbox because it addresses not just the lungs. All of our tools up until now have only addressed the lungs, whereas diaphragm neurostimulation is giving us the ability to actually impact all of those other organs as well, which is really, really exciting. The temporariness or the ability for it to be a temporary solution is great, meaning it's not permanent implantation, so the risk is much lower. And as the computer technology and AI starts coming up, I think there's going to be some really interesting applications of this technology.
Yeah, I think that really ties everything in together as well, especially seeing the
Mhm.
diaphragm. I don't think people often think about the diaphragm, especially when it comes to respiratory health, which is funny because it's so essential for that.
It's our
Um,
main motor. Yeah.
yeah. Um, but yeah, so I find that very interesting. We did also have a question in the
Oh,
chat.
great.
Just based on that, it was from Leah. She says, "What ventilators are you using for this new technology?"
So, what's great about this technology is it's ventilator agnostic. So, it can work with any ventilator, and it has been designed. So, certainly, all three companies that are trying to get the technology going have gone in not wanting to be associated with a specific ventilator. Right now, we have lots of other technologies, but they're because they were developed by the ventilator company, they have tied it to their ventilator. And so
Yeah.
that's great if that's the ventilator that you have in your hospital or that's the ventilator that you can afford. But
Hmm.
a ventilator costs $75,000 Canadian. And so if you live in a region of the world, like I did 3 medical missions to Haiti, and the ventilators that we had down there were the worst cheapest transport ventilators, and that's what they were using to manage their critical care patients because it's all they could afford and it's all they
Yeah.
had. And so they certainly don't have access to any of these advanced technologies.
Hmm.
So these companies, what was great about them, all three of them, is that they've gone in trying to be ventilator agnostic and to be able to, they work in conjunction with any ventilator, which is great.
That's amazing.
Did that answer your question?
It, yeah, Leah, feel free to chime in if you would like. We do have another question after that as well. From,
Hi,
oh
yes, this
yeah,
is Leah.
Hi,
yes, go
Leah.
ahead.
So what is the cost associated with the, I guess, the additional package for this
That's a great
technology?
question. So I don't know that we know that yet.
Okay.
Lung Pacer, so one of the three just got their FDA approval for using this technology in a rehabilitation sense. So for patients who had already weak diaphragms to make it stronger, kind of like physiotherapy for your diaphragm. It has not been approved in a prevention lung injury prevention application yet. Um, because the company is a US company, I don't think it's going to be cheap. So, unfortunately, s- but it probably will be. Um, I think my last conversation with the company was that they were going to charge for the catheters, and then they you would get the machine for free, kind of thing. And so then I don't know how much a regular IV catheter that goes in the neck is about $2,000. I suspect they're probably going to be maybe $10,000 a catheter. I don't know, but I don't think it's never cheap, unfortunately.
Well, that's not, you know, well, if it works, I mean, and it doesn't matter which ventilator you can associate it with.
For sure.
I'm just thinking back to when we were trying to use those ones that went through the esophagus with the servo eye.
Okay,
So
yes, the Nava catheters. Yep, absolutely.
yes,
Yep.
so that's not that far off. So, and if you can use it
No, for
between
sure.
different ventilators,
Absolutely.
it's
And
not that bad, and
no,
compared to
it's
ECMO.
perfect. Yeah, no, I 1,000%. No, I agree with you. And then, if you think about, what does a day of ventilation cost and how many days are so there's an economic argument that you can make for it as well. Absolutely, for sure. There was another question, Mark.
Yes, we did have one from Suzanne, or Susan, sorry if I said that incorrectly. Do all hospitals in BC use neurostimulation?
No, because they did not go for Health Canada approval. So they started with the FDA. We have some research projects. So there's hospitals in Toronto that are studying it from a research perspective. My hospital, we have two studies running right now, one looking at it for lung injury prevention, and one looking at it to be able to rehabilitate. Um, so lungs that are going for donation, but that are not good enough to be donated to see if we can rehabilitate those lungs and make them good enough so that we can improve the numbers of lungs that are going for donation. So we are doing a study on that right now. But no, there's nobody in BC has access to this from a care perspective yet. I think it's probably 3-ish years away for that.
Yeah, very interesting. I recall a Grey's Anatomy episode on that as well.
Don't believe what you see on Grey's
Yeah.
Anatomy, Mark.
Oh, I definitely don't from that show. Awesome. Thank you for answering that question.
No problem.
Yeah, I think the other ones we could save for after if you want to continue.
Sure. Because I literally have one more slide. So
Okay,
why don't we
perfect.
talk through role of AI and then we can open it up just generally to
Yeah.
questions. So artificial intelligence, it's everywhere. It's all over the news, everything. It's the big thing. Everybody has ChatGPT on their phone. I don't know how I lived before ChatGPT existed. Although maybe it was a good thing that I did all of my my academics without ChatGPT. Maybe I'm smarter today because of that. I don't know. Anyway, but AI is going to be groundbreaking and game changing for us in this field. One of the big struggles that we have in understanding the research and the data that we get from our patients is obviously our patients are very complex. The issues are very complex, and then there's a lot of noise. There's so many things that are affecting the patients that are not necessarily the ventilator, but we don't have the ability to tease all of that information out. What artificial intelligence is allowing us to do is be able to see the patterns in the noise. And that is honestly groundbreaking, game changing for us because suddenly all these things that we suspected, we have the ability to go and physically look at now. And that's really, really great because now I think we're going to have way less waste running down paths that are not going to pay off for us and be able to really target and hone in on the roots and on the research that's going to really be effective for us. So from a research perspective and from a data perspective, AI is going to be great, is already game changing. There's really cool research that was just published where the AI model that was running could predict when the patient wanted to take a breath as well as the patient's brain was signaling that with sensors directly on the brain. And so when we can do that, now suddenly the synchronization of our ventilators will become much better because we can anticipate versus having to listen. And that anticipation will help us overcome those inherent lags in the system. So that's going to be more comfortable for the patients. Our patients are going to get out of the ICU with less PTSD from being on the ventilator itself. It's going to allow us to really personalize our ventilation strategies. So right now, our open loop or automatic adjusted modes of ventilation, where the ventilator will make a lot of decisions based on feedback from the patient, they're very slow, they're very clunky, they don't work very well because they have to have so many safety mechanisms in place for them to operate safely with a low processor environment that ventilators historically have had. But as our processors are getting so much smarter and our AI models are getting so cool, now all of a sudden closed loop ventilation is becoming reality. You know, the self-driving car, we're going to have a self-driving ventilator that's actually effective and will put me out of a job clinically. And that's what I want because they can do it better than I can do it. They're watching the patient every minute of every day. I can only look after so many patients and look at them so many times in an hour or in a day. And so for our patients, I mean, it's not great for me, but for our patients, that's what we want. We want that 24/7 changing all the time, constantly reacting to their environment. And that is how we're going to give the safest possible mechanical ventilation. Artificial intelligence guided weaning. So being able to personalize a patient's journey off of the ventilator. The most dangerous point of a patient's mechanical ventilation journey is the point where they go from us making all the ventilation decisions for them in a coma and waking them up and having them breathe on their own. And so this with using AI guided algorithms, I think we will do so much good for our patients. And so this has just exploded, obviously, in the last 2 years. I am working with a group right now to be able to try to understand how can we do this the best. And it's very confidential, so I can't really talk about it. But this is very, very exciting. And I think about pairing AI with diaphragm neurostimulation and being in a sort of a self-guided, self-driven model. I think it's going to be revolutionary for our environment. So that's what I think the future of care is really, I think I'm going to be out of a clinical job because the ventilator is going to be so good and it's going to be able to self-drive in such a way and is going to be able to feed the data into the care team in such a way that we can look after our patients with a level of oversight that we've never been able to provide because we've been in a resource limited environment. And as we keep facing a future with less nurses, less RTs, you know, less physicians, we have to get smarter. So we have to figure out how we can process the amount of data in such a way that is efficient and that we can really give the care to our patients. I'm very excited to be out of a job in 15 years because the technology will really be able to look after my patients in a way that I haven't been able to up until now. So
Yeah.
that's my little plug.
Yeah, I think you're absolutely right about that. I think that that's especially in the medical world, those advancements are massive. As the resources, like you said, are limited, the people are limited to how much you can be awake and watch someone for a 24-hour shift.
Mhm.
It's just enormous what that can do, connecting the dots between pathways that you thought about but couldn't explore because they're too risky, maybe.
Yeah.
Yeah, endless.
Sorry, I realized I went a little long.
Oh,
I didn't
don't.
have a watch
Yeah.
in front of me, so I apologize for taking up the whole hour.
Oh, it's great. Yeah,
But I
there's
still have
no.
time if we want to do some more questions.
Yeah, absolutely. There were a few in the chat that I just sort of left for the end. Some more specific ones if you're open to it. It looks like
Mhm.
Candace had asked, are you researching the vagus nerve stimulation?
I am not personally, but there are many people that are for many different reasons. So you can actually on Amazon buy a vagus nerve stimulator and put it on yourself today,
Oh,
right? Yeah. And so people are using it for depression, people are using it for mental health. But there
interesting.
are, I'm not sure that I would go and buy one because I don't know that we necessarily know exactly what we're doing when we do that. But
Yes.
there is a ton of work that's being put into vagus nerve stimulation and understanding what it does and what its potentials are.
Yeah, definitely. It's definitely an interesting topic when you were briefly chatting about it. I was like, oh, that
Mhm.
sounds, I haven't explored that. I definitely will. Yeah, and then also from Candace had asked, isn't there a change in philosophy on how we position newborns? I don't know if Candace, did you mean position newborns for
Well,
ventilation
are
or?
they used to position them on their side, and then
Yeah,
I wonder if they're positioning them on laying on their stomach.
they are doing a lot of, yes. So we move them around a lot. So they tend to spend probably 60% of their time on their tummy, and then the other 40% is side to side and back.
Yeah.
Hmm, interesting.
Okay.
Um,
Well, that makes sense with the rest of what you were saying about
Yeah,
patients on a ventilator on their tummy.
yeah,
Yeah.
absolutely. No, for sure. And it also it's a lot of also the comfort of the babies too. If you can keep the babies feeling surrounded and tucked in, their stress goes way down. And so it's much easier to achieve also when they're on their stomachs than it is
Yeah.
on their backs. So
mhm.
Makes sense.
Candace, did you also want to just rephrase your last comment in the chat? Or not rephrase it? Say
What?
it.
Well, what? Okay. Well, everyone saw that. So my husband has a frozen diaphragm on one side.
Mhm.
Looked
Yep.
like the phrenic nerve got damaged.
Mhm.
So
Okay.
do you think that the phrenic nerve stimulation would work or
It depends
for
where the
patients?
damage is.
Mhm.
So if it's right, so if it's lower than where the insertion point is, then it won't work. If
Yeah,
it's higher than the insertion point, it would work.
yeah. Oh, it's lower.
Yeah. So it
Yeah,
would depend on what caused, if it was a surgical reason, if he was having surgery and they damaged it, then it tends to be lower.
yeah,
So
that was it.
yeah.
So,
And it's a lot of people that have cardiac surgery end up with injured diaphragms because they end
Oh,
up doing yeah, a significant amount actually.
yeah.
that's good to know.
Oh, that's interesting.
Yeah.
It's not good. Oh, jeez.
It's not good. And so one of the indications that we were looking at was when they go into surgery to make sure that you're keeping the nerve. So can we keep the diaphragm firing during the surgery? And so that they sort of have an awareness, not just keep the diaphragm active, but also is there sort of an awareness and that they know that they've damaged it when they've damaged it, so that they could quickly do a repair. Because sometimes if
Yeah.
you can do the repair in the moment, then
Yeah.
the damage is not permanent. So
Yeah, if you're not aware that it even happened, then that's
mhm,
totally different. But yeah.
yeah.
Yeah, that would help. That would be great. I'm sure that would reduce the injury risk significantly if they were just
Hmm.
aware
Yeah.
of a process they could do. Very cool. Does anyone else have any questions for anyone?
I don't, but I'd like to say, well, Liz, thank you so much for your presentation. I know
Mhm.
Mark's going to thank you, but TB Vets has supports respiratory therapists at Thompson Rivers University. And then we also have been the last couple of years supporting them with stethoscopes for students, where every new respiratory therapy student gets a new stethoscope. So
Yeah.
that's a lot of hard words to
Yeah.
say. Yeah.
Yeah, it's a
So
great program.
yeah. So I thank all our donors for helping us with those programs.
Mhm. Mhm.
And that's amazing. It's as a freshly graduated respiratory therapist, there is getting your first stethoscope is weirdly the symbol of the journey that you're about to go on. Number one, it's the main tool that you're using, but um, there is just something incredibly symbolic about
Yeah.
that stethoscope, and it's sort of this
Yeah.
anointing of the work that you're going to go out and perform. So I commend TB Vets in that program. I think that's amazing.
Yeah.
Yeah.
Thank you.
Awesome. Well, yeah, if no one has any more questions,
I do actually.
yeah, we do have questions. Go ahead.
Thanks. I was looking forward to this to kind of pick your brain as well. Um, I work in New Brunswick, and so as a respiratory therapist, and our doctors. Well, two of our doctors have gone towards very strict 6 mils per kilo
Mhm.
ventilation strategy, even in healthy lungs.
Mhm.
Regardless of the peak pressures, plat pressures, anything like that. Is there any? I've kind of looked myself, but is there any new research out that has kind of directed towards this, or are you still kind of, you kind of mentioned more 6 to 8 mils per kilo? I'd
Well,
be just
yeah, so
curious.
6 mils per kilo, right, is very much ARDSNet. A lot of the follow-up studies to ARDSNet, 6 mils per kilo is sort of our lung protective in ARDS lungs is what we're looking to achieve, right?
Absolutely.
But if you're having to sedate the patient to achieve that, then I'm not sure that because you're going to gain every lowering the pressures and lowering the volume exposure is a good thing, even in healthy lungs. But if you're
Absolutely.
having to give the breath more frequently because of
Hmm.
that, and if you're having to sedate the patient, I'm not sure that the trade-off is what you think it is. And so, yeah.
I agree. Okay. I was just curious, if there'd been something out about,
Mm-mm.
this 6 mils per kilo, even in healthy lungs, like in some of our post-op patients. Um, but yeah, ArtsNet, absolutely no problem. But
Mhm.
we were kind of
Mhm.
scratching our heads about where this new
Mhm.
philosophy came from.
Mhm.
So, and yeah, I've kind of done a broad search for research, but
Mhm.
um,
Yeah.
so okay, just curious. Nice to know what other people are doing on the other side
But
of the country.
but ventilation culture is very much unit based, right? And so as much as the research says what the research says, the individual intensive care units and the ventilation culture that's within those units. I did my postdoctoral fellowship in France, and seeing how they ventilate in France compared to how we ventilate in Canada.
Oh,
And this is like at a very high level ventilation research center. So it's not that they're not aware of the research, but it's just there is a culture around ventilation too. And so people do what they're comfortable with, or what they've grown up with, or what the unit uses often. So
okay. Thank you very much for your perspective on that. This was all
welcome.
very helpful. Much appreciated.
Great, my pleasure.
Well, it's fantastic. 2 RTs and 1 webinar.
There we go.
Well, great. Yeah. Does anyone else have any more questions? I'll take that as a no.
Yeah.
Fantastic. Well, thank you everyone for joining us today. And thank you again, Liz, for a wonderful
My
presentation.
pleasure.
So
Yeah, thank you, Liz.
insightful.
Absolutely.
Yeah, and we really look forward to seeing where the technology grows and your research as well. Yeah.
Thank you for all your support. I wouldn't literally don't think I would be here without TB Vets, because you supported the person who I did my PhD with, and you're currently
Yeah.
supporting me. So this is
Yeah.
very much a testament to your support. So thank you.
Yeah, and we just love to see that grow continuously. It's great. It's
Awesome.
fantastic.
Great.
Yeah.
Well, have a great day, everybody. Thank you very much.
You too.
Take care,
Thanks, Liz.
everyone.
Take
Bye-bye.
care. Bye.